The views expressed on this podcast are those of its host and its host alone. The purpose of this podcast is for education and entertainment and not to diagnose or treat any health condition whatsoever. Please talk to your doctor if you have any concerns about your health.
Welcome to Crash Cart. This is a well-perfused production. Welcome to another episode of Crash Cart, the internal medicine podcast. I'm Noah Blaker.
I'm Faz Salat. I'm Kernal Shukla.
And we are internal medicine residents here to talk about an exciting topic, which is goals of care.
Today we have the show notes provided by Dr. David Giddis, a wonderful PGY3, now a first-year fellow, cardiology fellow upcoming, and peer review provided by Dr. Paige Barker, an expert in palliative care at the University of Florida. We hope you enjoy today's discussion.
Alrighty, so I know this is the most cheery topic that we've had on the show so far, but, why are we doing this? Why are we talking about goals of care?
Sure, Noah. So goals of care are essential. They can be a frustrating part of our jobs at times, but they help identify what a patient cares about. You can then move them towards that goal. And that's how I see goals of care conversation. There are a lot of misconceptions when people hear about goals of care, but one thing that I really like to clarify is goals of care does not equate to end-of-life talk.
What do you mean by that, not equated to end-of-life talk? What else could it be about?
It could be essentially anything that the patient wants out of their treatment plan.
Which could include full care, right?
Exactly. And if they tell me that, then that's exactly what my medical team will do.
I think that's a great way of thinking about it. And in fact, it brings up an interesting topic, which is when to have these conversations, which is often when things are actually going pretty well, rather than in dire circumstances, so that we can have an honest and frank conversation about what's important to the patient. One of the things we often encounter is, what if a patient's goal doesn't make sense? That can be really challenging, and specifically when we talk about code status or when we talk about pursuing treatment when we as medical professionals feel that it may be futile. By seeking to understand the patient more than having them understand our medical thoughts on their situation, we can kind of see where they're coming from. For a lot of people, medical death is important. Once you've explained to them the statistics surrounding codes and the treatments and the options available in their prognosis, if they still want to proceed with treatment, it makes sense to then proceed with treatment and proceed with being full code. And this benefits both the patient because they are being understood, but it also benefits the provider. Number one, you're on the same page with your patient, and there's data to suggest that this actually lowers rehospitalization rates and hospital readmissions. And not only that, it makes you feel better as the provider knowing that you're treating the patient exactly how they want to be treated, even if you don't agree with the decisions that they've made.
No, that's so true, Noah. So I just wanted to go back to what you mentioned, how do you usually approach this conversation about code status with patients?
That's a great question. I think code status specifically, number one, seek to understand before being understood. Say, hey, what do you know about this process? Have you ever seen one? Do you have a family member who's been through it, or have you seen it on TV? And based on what they say, you can kind of meet them where they're at. One of the things you then do is just kind of talk about the statistics. I really would urge most people to avoid using scary language. And by that, I mean trying to scare somebody out of being a full code. Hey, we're going to break your ribs. You're not going to make it anyway. And this is going to increase suffering. Mentioning the suffering is valuable, but in the context of the statistics. Say things more like, hey, I just want you to be aware we only get healthy people back within 10 to 20% of the time. And by that, I mean success is getting a pulse back for any length of time. That does not mean getting off a ventilator. That does not mean leaving the hospital. That does not mean having any quality of life in the hospital. If you're willing to accept those odds, then I'm willing to provide you with that service, and is often how I present it.
One thing I would also add is going over code status is just like providing informed consent of any other procedure. You give your risks, benefits, and what the process would look like. So I think within reason saying these would be the chances of possibly, quote, coming back. And coming back may or may not look like what you want it to look like. Very rarely is it a, quote, full recovery. Sometimes your loved ones may return in a different way. They may not be able to speak to you. They may not be able to function independently, or by off chance they might. But here is what we realistically foresee.
And that realistic foreseeing part is important because for a lot of people, even if the odds are slim, medical death is important to a lot of people, meaning dying in a hospital knowing that everything has been done. That is part of their ethos. That is part of who they are as people. And we shouldn't deny people that just because we would make a different choice for ourselves.
That's so true. It's a great point that you and Fez made, that medical death could be very meaningful to people. And at the same time, is very important to highlight the quality of life that they could have after resuscitation. So that takes me to like a next question that I have is, how do we approach this with patient and their family?
That's an awesome question. And it's something that about a year ago, when I was an intern, back in the day, as some would say, I very often I'll be honest, I was apprehensive having these discussions because these are very intimate and heavy discussions to be having with an otherwise stranger, quite frankly. So I think I've grown to appreciate that there are two principles in general. One is you have to have a structure. This is not a conversation you go into blind. You have to have known your patient. You have to have had some degree of rapport, and generally there should be structure. The second principle is that whatever structure you choose, whatever acronym you use to organize your thoughts, for example, generally you should have some element of establishing trust, as I mentioned before. Assessing the other parties, i.e. the patient's understanding of the situation, and then finally walking away with clear goals from the patient and a clear plan from the provider team of how we achieve those goals. Now, one of the clinically validated frameworks, and one that we've heard of a lot, is called the SPIKES framework. I know there are a lot of acronyms and sort of ways to remember things, but I find that this is actually quite helpful. So just as a review, maybe we've heard this in med school, but SPIKE stands for S being setting up the interview. So assess, is now a good time? I mean, if they are, having a private family moment, for example, and you have just realized that, recent imaging results have shown that a given condition is far more prognostically worrisome than it was before. You don't just barge in when when it's not the time. So read the room. Ask the patient or their family, is now a good time to talk about some important updates? Second would be P, perceptions, assessing the patient's perceptions. Before I barge in with medical jargon and what information I have, what do you know about what's going on? Third is obtaining the patient's invitation being I in SPIKES. Asking them, are you okay with me, now that I've heard what your perceptions are you okay with me sharing what the medical team has seen? And finally, step 4 would be K, knowledge, giving knowledge and information to the patient. So now sharing in understandable and empathetic but clear terms, and not beating around the bush what prognostic factors lie ahead. That leaves E and S in SPIKES. It's not a matter of just delivering the information. It is also our responsibility to deal with, the aftermath. Sometimes telling a patient about a terminal diagnosis leaves them understandably in a lot of distress. And part of our job is providing support in that distress, assessing their emotions, telling them it's okay to feel anger, to want to blame someone, to feel powerless. These are all natural emotions. And finally, after some time, providing strategy and summary, summarizing what we talked about, summarizing the goals, having them repeat back what they understand, and you yourself repeating what they wanted. One thing to note is this framework does not happen necessarily in one conversation. This could be a matter of days, even weeks sometimes. I mean, Noah and Krunal, we've all seen patients in the hospital for what, like 5-6 months? What's the longest you guys have seen?
Probably around that long.
At least 6 months at times.
And I mean, those conversations last for a while. So
I think one of the things that you bring up is prognosis, and preparing for these conversations is so vital. And one of the parts of those preparation is to understand the patient's condition so you can share that information. Prognosis can also be tough because the common question that patients ask is, well, how long do I have? And none of us know for sure. One of the best ways I've heard it put by our palliative care expert is, hey, in a football stadium full of people, I know which sections of the stadium are going to die in 6 months, a year, and 5 years. I don't know where you, the patient, are sitting in the stadium. And I think that's really powerful, and it also sets the expectations for the patient on what they can expect out of us in terms of information so that they can make the best decisions possible for their goals of care based on the information that we are able to give them.
No, those are some great points that you make, Noah and Fez. Something that I also wanted to focus on was like the language. Like when I started intern year, I didn't know how to start these conversations or what questions I should ask in a way that the patient and their family would not be offended. One statement that I love using is, I hope for the best, but I worry. And then when I'm asking them questions, I like to keep things open-ended. So I ask, like, what matters most to you if your health worsens? And I think that usually starts the conversation for me. And after that, the family and the patient, they start thinking about what they want. And a lot of times I don't even have to prompt them any further, and they start telling me what they want out of their treatment plan.
Yeah, as both you and Fez pointed out, number one, you have to introduce the idea to the patient, and that can be challenging. And also that these conversations can take days and happen slowly over time. One of the things that I use in order to do that is to ask abstract questions early on so the patient can be a little bit objective about their own situation. You ask for permission. Hey, can I ask you a wild question? And then you say something like, if they say yes, obviously, you say something like, what if I said you were never going to get better? Would you make different choices, or would you do what you're doing now? Or what would you want to do? And they can kind of play with that thought experiment a little bit in a way that doesn't feel quite as serious as when we're talking about their care specifically. I think that can be really helpful. The other thing, we've given a lot of information on this podcast, but a lot of this comes down just to spending time with the patient and listening. One of the best pieces of advice I was ever given in patient care was very simple. And if you remember one thing from this podcast, it can be this. When you go to see a patient, especially for goals of care, introduce yourself, wash your hands, and sit down. If you do those three things, you will already be opening up a line of communication to the patient where you can really understand what they are looking to get out of their care.
That's a great final point. So I'll try and put together a summary in case those with ADHD have forwarded right to the very end. Sometimes I'm guilty of that. But it sounds like from what we've heard from Krunal, Noah, myself, is that in general, build rapport, take your time, know the patient, be organized, whether it's goals of care or a discussion about code status. That includes anything like a spikes framework to some sort of a structured method. And then use the appropriate language. Some of the examples Krunal gave, one of which was, if your health were to get significantly worse, what would be most important to you? That being said, I would summarize also by saying goals of care discussions are possibly one of the most important medical interventions we can do as physicians. Maybe second to GDMT, but I might be biased.
Couldn't agree more. I think being able to be there for your patient during their most difficult times and being able to give them exactly the care that they want in any situation is really a gift in medicine and is one of the reasons why we do the job. So I know this hasn't been the most cheery of all episodes, but we appreciate you sticking around. We really think that this topic is super important to talk about, to understand, and to reduce the fear and anxiety surrounding having these conversations. And we hope you learned a lot. Tune in next time for our next exciting episode on Crash Cart. We look forward to seeing you there.